Currently, for melanoma patients, sentinel node biopsy is advised to provide information on the prognosis of these patients. This is being advised for melanoma patients who have a melanoma with a breast lobe thickness of more than 1 millimeter, or if there are risk factors present in the primary tumor such as ulceration or a high mitotic rate. Currently, the sentinel node biopsy is the most accurate way to provide us with information on the prognosis of each patient. For this study, we selected almost 4,000 patients from 9 EORTC melanoma group centers, and they were divided in a group of sentinel node positive patients, 998 to be precise, and a group of sentinel node negative patients, 2,886 patients, and all patients underwent sentinel node biopsy according to the local guidelines, and were operated upon between the late 1990s and until 2012. So this is the study group we used. We looked at the differences in baseline characteristics for the sentinel node positive patients and the sentinel node negative patients, and also we divided the group into patients who were operated before 6 weeks and patients who were operated after 6 weeks. For the sentinel node negative patients versus the sentinel node positive patients, we found differences in breast lobe thickness. This was higher in the sentinel node positive patients, and as well as ulceration of the tumor. This was also more often present in sentinel node positive patients, and all the other known risk factors for a positive sentinel node, such as location not on the extremities, a nodular melanoma, and presence of high mitosis, high mitotic rate. And when we looked at the differences in baseline characteristics for the patients who were operated upon early, so within 6 weeks, versus later than that, we didn't find any differences in the sentinel node positive group, but in the sentinel node negative group we saw that early operated patients were usually older, 57 compared to 53 years of age, and also had a thinner tumor, so the breast thickness was less in patients operated early. The main finding of this study is that the time interval which is taken until the sentinel node biopsy is performed in melanoma patients has no effects on the disease-free survival or the melanoma-specific survival. So it doesn't matter if you perform a sentinel node biopsy within 2 weeks, for instance, or after 9 weeks. Given the fact that this time interval until sentinel node biopsy has no influence on melanoma-specific survival, the sentinel node biopsy remains as the most accurate staging procedure, as it provides us information on which patients will die early due to a positive sentinel node. For this, the sentinel node biopsy still has to be performed for each melanoma patient. Okay, as the time interval when the sentinel node biopsy is performed has no effect on survival, this can be used in clinical practice to reduce patient anxiety, as we have clearly shown that it doesn't matter when you perform the sentinel node biopsy. However, we believe that it shouldn't be the case that patients are now going to be operated upon much later than what is usual. So within 6 weeks is fine, but you shouldn't stress it to be longer or sooner.